share the okay. I have stopped sharing, I think. Yeah. Yeah, please. Yes, Arun, please. Please put on the prayers, please.
आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Arun. With that, since I have already introduced the topic for today, I invite Dr. Durgadas Sasran, the president of Kasoga for the year 25-26, to say a few words. I must thank him personally for giving me the opportunity. Though I am the secretary, I cannot take it for granted that I can do, and I must seek his endorsement before I float any program. So thank you for that. At this point of time, I think I must mention our patron, Dr. M.G. Hiremat. He is otherwise engaged, so he is not able to be there. And our other patron, Dr. Nagaraj sir, who is our veteran and like our father figure, he also is unable to join. I now request sincerely Dr. Durgadas Sasrana. Sir is shown remarkable capability as a president in this year. I must inform all the delegates who are outside Karnataka that we have robust 24 societies of OBG in Karnataka, and Dr. Durgadas has been a very effective leader this year. Apart from the wonderful state conference that he conducted at Tumkur, he has been instrumental in floating several new programs. So over to you, Dr. Durgadas, and please connect with the audience here. Thank you.
Good evening, everybody. At the outset, I thank our own dynamic secretary, Dr. Shobha Gudi, for bringing so many stalwarts to House of Kasoga today. Dr. Mala Arora, Dr. Prajna Chaudhary, Dr. Kiran Pandey, Dr. Seema Sharma, Dr. Priyadarshini, and Dr. Priya Ranganath. With respect to Dr. Mala Arora, we have seen the dedication of Dr. Mala Arora in the field of recurrent pregnancy loss. Her lectures on RPL was mesmerizing, and the books she has written on RPL is a referral book for all the postgraduates as well as the consultants. We have watched her passion in this field that has given birth to the Indian chapter of RPL Foundation. We all wish you good luck in this endeavor. And madam, I assure you from Kasoga, whatever support you want from our Kasoga, Karnataka, we are ready to join hands with you in this excellent project. Dr. Kiran Pandey, the past chair of the Medical Education Committee, is so affectionate. I have enjoyed her hospitality in Kanpur while I was in Kanpur for the IMS conference. The memories are still vivid in me. Dr. Prajna Mishra, who was the chair of Fetal Genetic Committee of FOXY, is a frontliner leader of FOXY and ever enthusiastic. I am looking forward for this wonderful ISOPAR meet in Patna shortly in March. With these few words, once again, I say good luck to Dr. Mala Arora and her team, and best of luck for this wonderful event. And once again, I assure you, Kasoga, whatever you want, anyhow, our friend Dr. Shobha is there. We are ready to join hands to whatever you require from us.
Thank you,
Thank
sir.
And best of luck to you.
Thank you.
Thank you. I request Dr. Rajeshri Paladi to say a few words.
My pranams to all the senior members of FOXY who have come on an invitation to this platform of Kasoga. It's been a wonderful exchange of academics across the states and the borders we all have. And this will definitely enhance us in our learning towards serving better for the women, and especially the genetics topic, which has been chosen for the recurrent pregnancy loss. And we know that the stalwarts here, Dr. Mala Arora, who has done a wonderful, extensive research work regarding the recurrent pregnancy loss, and Dr. Shobha has rightly brought in all the members to deliver their best of their skills and knowledge. And I'm sure that a lot of us will be benefited from understanding the new perspective, better aspects of knowing the current pregnancy loss. Ever since my postgraduate years ago, that was a topic of my choice. And even now, we have so many unanswered questions and new learnings that crop up every year. And thank you for taking up these topics. And over to you, Dr. Shobha. Thanks.
Thank you. Thank you, Rajashri. Can I have the CV deck to introduce the guests of honor very, very quickly, please? Arun? Yeah. Show me Kiran Pandey, madams, because I can't see Pragya Chaudhary. And meanwhile, okay, let me introduce and we will take her message if she is there. Pragya, are you there, Pragya? आप हैं यहाँ पे? Okay. So Dr. Pragya Mishra is from Patna and currently she is the president of Patna OB-GYN Society. She also has her own center as she is an IVF specialist. She is the Secretary General of the National Organization ISOPAR, a very vibrant society which works for perinatology. And she is featuring in the ICOG also as governing council member. Just past, she was along with me, ICOG Governing Council member. She has founded the Bihar chapter of ISAR and a lot many accreditations to her. So we welcome you, Dr. Pragya, to Kasoga. Next, please. Dr. Kiran Pandey, thank you specially for being here. Kiran is a very, very dear friend. She was recently completed as chairperson of the Medical Education Committee of Foxy. Wonderful work done by her, a very senior teacher, excellent teacher. And she was also, along with me, governing council member of ICOG 2325. Is peer reviewer for Jogi also. And she has been the past president of Kanpur Menopause Society. And I'm very happy to have her here today. And with that, over to you, Kiran. If we can have a few words from you, we'll be delighted. Can you stop sharing,
Thank you.
please? Thank you. Yeah.
Thank you, Shobha. Thank you very much for inviting me. It's really a privilege and honor to be part of the Kasoga programs. And thank you, Dr. Durga Das. It's nice to see you as a president, Kasoga, and taking charge and doing such wonderful programs. Of course, I will miss Dr. Hiramat and Dr. Nagraj. Their blessings would have been very important. But friends like Dr. Bharti and Dr. The Rajshri, all of you are there.
Yeah.
So it's a
Yeah.
very good thing. The topic which you have selected is a wonderful one. I would say genetics, it is really explains most of the early losses, although we can't say, but I mean, like, not all are the RPL are genetic, but still, like 60-70% of first trimester miscarriages may be chromosomal, and out of that, many have a genetic factors like balance translocation, etc. in 2 to 5% cases. The basic thing is, I would like to say in very short that recurrent pregnancy loss, the genetics definitely gives her many, many answers. But we should also remember that the empathy gives us healing, which we all have to remember. And as we advance in, I would say, in decoding the genome, which is, I saw one of the topic part in this also, the genomic significance. So we have to remember that we have to also have to understand the human story behind it. Many, of course, POC testing is always has to be done. Parental karyotyping still remains fundamental, although 2 to 5% may have the balanced translocation, etc. Now the era of PGT has come in IVF. Maybe PGT-A, like the aneuploidies, all of you know, very common, which will be discussed. Mala is I would say, the master and grandmaster of RPL. I've read her book and I've seen her programs. She is very, very well known. also the future of the genetics is also very important. In which one thing I would like, there are so many things, but just one thing. Now the era of AI has come. So now, somewhere I was reading the AI based embryo selection is all may become also a reality, ground reality, or the further. I mean, the we are advancing towards that. Besides the other thing like polyembryonic risk profiling, that epigenetic markers, and the genome sequencing definitely has a great role. So, I mean, this is such an interesting topic, because whenever the RPL patient comes, we all become sometimes you give everything and still the result are not there, and you feel that patients, the torture through which they are going, the couple is suffering. So there it becomes really very important that if we are possible, we can make unexplained RPLs to the explained one. Maybe whatever it is, we can do something or we can not do,
Yeah,
because
exactly.
sometimes they even have after three losses also normal chances of
Chances are there,
pregnancy.
definitely
Yes.
correct.
So you have to remember this,
Yeah.
and that is why I said in the beginning that empathy still matters. And
Yes,
oh, that
correct.
our Dr. Sudesh Sharma in Kanpur, she was a very good person. She
Hmm.
used to always say, Meera ji ki ki TLC, total the
Tender loving
total
care.
love and care. That is the one
Hmm.
thing which matters.
Exactly, exactly. Hmm.
So let's go and hear the Mala, because she will definitely
Hmm.
come out to be the most important and
Yeah.
newer things. That's the, and let's hope,
Hmm.
wish
Thank
that
you, Kiran.
healing of
Thank you.
us. Thank you.
Kiran, that
Pragya
was
is
such a
right.
wonderful.
Pragya.
Yeah, yeah, yeah. Such a wonderful message, Kiran. Thank you so much.
Thank
So,
you. Thank
welcome to
you.
Pragya Mishra. Come, Pragya, in
Yeah,
between your
yeah.
preparations for your ISOPAP conference you have joined. Thank you very much. We have already introduced you, and
Oh,
all
thank
your
you.
credentials were told. Please give us a brief message on this. You have also worked in this field, constantly working in this field. So, genetics in RPL, please. Yes. Yeah. Kasoga is waiting to hear.
Yeah. Actually, if you give me just 2 minutes, my laptop is also getting connected. Anyway, it's all right. I don't want the two to start together and it'll start echoing. Anyway, I think it's taking. I think I'll just speak on the mobile itself. Yes, first of all, thank you, Dr. Shobha Goody, for having invited me as a guest of honor and confirming this honor on me. Because, generally people forget, because it's been a while since I was the chairperson of
Oh, I don't forget.
genetics
Oh,
and
no,
fetal
no,
medicine.
no.
Thank you so much. Just like, I never forget you when it comes to family welfare and contraception.
Thank
So
you.
because you have done such good work.
Thank
And
you.
my co-guest of honor, Dr. Kiran Pandey, who has just finished with such a successful tenure
Thank you,
in the
Pragya. Thank
medical
you.
education. Yeah, it was indeed wonderful. I mean, your visits to Patna also.
Yes.
First of all, so thank you, Karnataka State, for this initiative. Dr. Shobha Goody is really, this is like a themed CME focused on the genetics of
Yeah,
recurrent
we
pregnancy
call it
loss.
the veritable chat show. And Pragya,
Yes,
Dr.
yes.
Durgadas was very keen to meet you. He's our president. Yeah,
Oh,
he's our
yes.
president. Yes,
Yeah,
he
I was just
actually
going to,
spoke
yes,
about
and
you
the
initially. Yes,
patron Dr.
Hiramat.
NG Hiramat. So
Uh,
when I was a chairperson, that time he was one of the vice presidents of
yes,
Foxy.
exactly.
And yes, and the
Exactly.
current president of Karnataka chapter, Dr. Durgadas. I mean, I've met him,
Correct.
and all the other people, who have you and the other and Dr. Shobha as treasurer, and all the people who are involved. Because I understand, when everything is put together in a flyer, it seems, so easy. But I do know that how much of effort has been involved, and the time taken to organize a CME like this. Now, This, I mean, one thing I would like to say, I just heard a little bit of what Dr. Kiran Pandey said, but, I've these days, now, well, earlier, we were more worried about the costs and all that of doing the tests. That time, yeah, I think, this has just started. So just one sec.
Pragya, we were able to hear you and see you very beautifully.
Okay, okay. No, I'm worried that, anyway, it's okay. So that people first we were bothered. People were not even like almost a decade ago, I would say, people were refraining even from ordering karyotyping because the test was costly. But now what has happened that the pharma companies they are offering a package. And it's not just enough to do a karyotyping. We should do chromosomal microarray as well because of the micro deletions and the duplications. Because otherwise, we miss out on many abnormalities which actually a couple would be suffering, would be afflicted with. That's something, and because of this package, the cost has gone down. So I would just say that whenever we are doing a peripheral blood karyotyping on the husband, on the patient and the partner, go for both, right for both, like karyotyping and chromosomal microarray. So that's something important that I would like to say. And of course, and many a times, what happens that some tests which come back as they are quite inconsequential. So those are the times even the general obstetrician can sort of reassure the patient that this particular genetic like sometimes we get some variants and copy number variants which are inconsequential. So we really have to tell the couple that this is probably not the cause of your recurrent pregnancy loss. So it can be quite reassuring at the level, at the obstetrician's level only. It could be something else, not essentially because of that, because otherwise, we really frighten the patient. So, secondly, we have to tell them, and of course, when the genetic tests come back as when we get translocations and all that. So in those tests, we really need to refer them to a geneticist. Ideal would be because only then a proper counseling can be done. When you find all these abnormalities. And as I said, and I heard Dr. Kiran Pandey also say that some patients, 50% of the times it's idiopathic. We don't find the cause. No problems with karyotyping, no problems with antiphospholipid antibodies, and still, every time the patient. So I would say that don't forget to do a semen analysis. Many a times, we just focus on the genetic test and we forget about the semen analysis of the husband, because that can also be a cause of RPL, especially if the count is low or the motility is low. So and we have to focus on the tests, like so many tests, because if a patient comes with oligospermia or azoospermia, there are certain tests which we have to do on the male partner also. Uh, so I think these three messages I would like to just give,
So
and
wonderful,
even
Pragya.
I'm quite eager to listen. But
Yeah.
yeah,
Yeah, you
so and
keep it on
it
and
would. It's
whatever
in
goes
fact
in,
I
goes
just
in. Yeah.
yeah. I mean, because I was just looking at it, and you have such wonderful. I mean, you have Dr. Mala Arora, and a long time back, in fact, I contributed in her book also.
Yes, yes.
So I mean, you have great speakers also, and who are yeah, presenting cases, and it would be quite good to have such focused CMEs, and looking forward to see you in Patna for the annual National ISOPAB conference. Thank
Patna,
you.
thank you so much, Pragya. That was so wonderful. And your
Yeah.
presence has really made a difference to the beginning. You and Kiran have really lighted up the webinar. Thank you with your radiance, and you bring in a lot of energy and goodwill. Thank you very much for being here. So from
Thank you,
here
Priya, for
onwards,
remembering me.
thank you. So from here
Thank you.
onwards, I start the scientific session, and I request Arun to display the CVs of the faculty today, so that in 2-3 minutes I can bring them on. So first and foremost, I have Dr. Marla Arora. You can see her credentials here. She has been the chairperson of ICOG in 2017 and vice president of Foxy in 2011. She belongs to the lovely city of Faridabad, and she has been an editor for the yearbook of ICOG year after year, and I had the good fortune of doing it with her in the past year. But the most important part of her work is perhaps she is a very empathetic IVF consultant, has got wonderful results, and has been the chief editor of Recurrent Pregnancy Loss, 3 volumes, 4 volumes, I think, so far, and also the World Clinics in Obs and Gynae. She has been awarded also for her editorial and authorship, and associate editor of International Journal of Infertility also. Recently, she has started an Indian foundation for dedicated to recurrent pregnancy loss, and very soon we will be listening to her on that. She'll briefly introduce the foundation and the journal that she has started. Next, yeah.
CV. This is a
Hmm.
very old CV that
Very
Yeah.
old, I know that. I
I'll
picked
send
it
Uh,
up.
you a
Please
this
go
PDF.
was the
forward.
this was the
Yeah.
book in which I had contributed first
Yes,
trimester of
Pragya. Yeah.
pregnancy.
Go forward, please. I don't need to be introduced to this audience. So we have the guest today, faculty, Dr. Priyadarshini Pandey, the geneticist from Delhi. She's obtained her master's. No, she's from Mumbai. She's obtained her master's degree for Maharaj from Sayaji Rao University, Department of Microbiology and Biotechnology, and she has been trained in US also at the Utah State University, and she has over 10 years of experience in R&D in pharmaceutical, biotechnology, and molecular diagnostic sector in USA, UK, and India. She has got a very rich body of work, several publications, and we welcome her to this. And I'm sure that her contributions will be of very high value. Next is we have a clinician here, Dr. Seema Sharma, senior consultant OB-GYN from Delhi, and very closely working with Dr. Mala, founder director of Indian Recurrent Pregnancy Loss Foundation. So she is very closely associated with Mala in this, and she has a special interest in this subject as well as in sexual medicines. Again, a very prolific author. Next, please. Welcome, Seema, to our session. And then we have someone very close to our heart is Dr. Priya Ranganath, a very proficient geneticist from Bangalore, consultant medical geneticist at Apollo Hospitals, and adjunct faculty to KMC Manipal. She has been certified from Harvard University for cancer genomics, and has undergone DNB super specialty in medical genetics from NIMS Hyderabad, and of course MS from Mysore, the very best college that can be in Karnataka, and MBBS from our dear, our own Bangalore Medical College. So really a lot of academic achievements, Priya. We are so proud of you. And she is also a gold medalist. So you are really awesome. My God, I'm afraid of your knowledge. So with that, we will stop this CV presentation. Yeah, and now I request Dr. Mala Arora to say a few words about the foundation and to share the screen if you want. Yeah,
Yes.
after that, yeah. Arun, please enable, na? Yeah, thank you. Yes.
Can you see it?
Yeah, we can see it.
So, a very good afternoon to all the dignitaries and the delegates that have joined. And my interest in RPL started when we looked at this huge population of unexplained RPL that baffled both the patients and the clinicians. And I thought This is an area that needs a lot of research, putting our brains together to crack the code of unexplained RPL. And I was very fortunate that me and Seema thought alike, and we both together registered the Indian Recurrent Pregnancy Loss Foundation in 2024. And this foundation, in the last 2 years, has been doing tremendous work. We are committed to do a multi pronged approach. One is to increase public awareness, and the second is to educate doctors to the correct or evidence based management of couples of RPL. We have a website, irplindia.org. We are working on a YouTube channel, and we have a few social media reels to educate the public. The aims and objectives of this foundation are, number one, to create public awareness so that couples don't wait to get pregnant before they go and see a doctor if they've had one or two miscarriages. And for this, we rely both on print media and social media. And this is an article we published in Femina magazine. And then we want to create awareness among practitioners, like through this program today with the help of Kasoga. And I thank Kasoga for bringing us on. We also did a similar, a very extensive program on genetics for the obstetrician in Delhi at the Habitat Center, which was a huge success. And in order to bring all research on RPL to one platform, we have launched the International Journal of RPL, which is under aegis of both the Indian RPL Foundation as well as the International Society of RPL. And the journal has got the first issue is already out. It's an open access journal, and you can access it on www.igrpl.org. It was launched in Chennai last year in 2025. And we are currently working on the second issue of this journal, and we would welcome any contributions because this is a peer reviewed journal which has already been awarded an ISSN certification. And we want to initiate our first program, which is just going to be launched very soon, is to study the association of vitamin D levels and pregnancy outcomes in women that miscarry and in women that go on to have a normal live birth. And this is going to be a retrospective cohort study. And we have just completed the concept note for this study to start work on this. Apart from that, we have regularly brought to you books updating your knowledge on RPL. And this all started in 2003 with the first edition of the book on RPL. And then 2007 was the second, 2018 the third, and now 2025 was the fourth edition. We have already now started work on the fifth edition of this book, which we aim to bring to you in a year's time. So I think our aim is very simple. We want to bring together like-minded researchers, academicians, and we want to inform all the members present here that we have a life membership open for the IRPLF Foundation. You can write to me or Dr. Seema, and Dr. Shobha has both our numbers. The benefits you get if you become a member is to be part of group discussions where you can discuss your difficult cases of RPL, where we are soon going to launch an RPL board where you can take a second opinion online of your patients that you see in the clinic and then get to know which way do you need to proceed, what tests are most important to be done for this patient. There will be regular conferences to which you will have discounts. You will have a link to the International Journal of RPL, and you would have discounts to the World Congress of RPL. The next one is planned in September 26 in Leiden, Netherlands. And here, the world's who and who come and present their research. And then, of course, you would be encouraged to participate in research activities. So I think I want to encourage all of you to kind of be associated with the foundation in some way or the other. And I think becoming a member is going to greatly benefit both your clinical practice and your knowledge on RPL. This is the address of the foundation's bank account, but we can obviously be in touch with you if you're interested. Now, why did we choose genetics and RPL? Because both genetics and epigenetics are currently playing a huge role in recurrent pregnancy loss. And this pie chart is from a researcher in Japan called Mayumi Ogasawara. And she has published more than few hundred publications on RPL. Look at this data that she published in Fertility Sterility in 2010, where she had 69% patients where they could not find any cause. And this is about time we switched from karyotyping to CMA, or comparative genomic hybridization. And the future same clinic reported that now, after doing genomic hybridization, they had a true unexplained incidence of only 25%, where a lot of them showed abnormal embryonic makeup. So you can see how important genetics is. We need to know which test to do and how to interpret it. And I think this will definitely help your practice in RPL. I will leave these slides for later on once we present this case. And with
Yeah.
this, I will hand over to you, Shobha, to carry on.
Mala, can we have the one previous slide?
Yeah,
I'll just take a picture and post it in our groups. It is really a lot of education in the
yeah,
picture itself.
right.
So, how generous of you to share every bit of knowledge that you have, and really appreciate your work greatly. Yeah, I have taken a picture. Yeah, yeah, yeah. So this is a good one, good publication. We can go online also. Yeah.
There's one more
Okay.
paper from
Yeah.
USA which said that they found answers in 94% of cases of RPL, but that work has not been duplicated by many others. But certainly the buzz is that genetics can decode a lot of miscarriages for
It
you.
looks like that. It is beginning to look like that. And as Kiran was saying, maybe artificial intelligence will also kick in sometime.
Why not? So
Yeah.
we have to
Okay.
combine genetics with metabolomics and
Yes.
proteomics, and then we will have more answers.
Correct. Correct. Yeah. Okay, Mara. Let us go ahead with the slide presentation. Yes, please.
So I'm done with my
Yeah.
introduction
Okay.
foundation, and I'd stop sharing now so that you can
Yeah.
carry on with your cases.
Yes. Yes. Okay, so thank you for that. And that was a wonderful introduction to the whole subject. So now permit me to start, and let me tell the audience that today there will not be any didactic lectures, and we will be having a slide presentation with the information on that and some cases. And in between, I will be switching off the presentation whenever there is a more discussion to be done, and we will take inputs from all the experts. So here goes. Let me just share my presentation with the. I hope it is all seen.
Mm-hmm.
Yeah. Right? Okay, fine. So then genetics and recurrent pregnancy loss as a definition, RPL, of course, affects only 1 to 2% of couples. And I will take a moment here to tell that it is possible that the quantum of RPL that we have at hand is probably the maximum in the world. Because you all know that we have the maximum number of pregnancies in the world. We are indeed the most populous country. We are 144 to 145 crores, and we are inching towards 150 crores very soon. So that means that 1 to 2% of this many couples who become pregnant every moment are going to have recurrent pregnancy loss. So we do have a large number of cases, and as Mala was bringing forward discussion on research, I think we are correctly positioned to have good material for research in this area specifically. So of course it is now accepted that 2 and more than 2 failed clinical pregnancies, which are documented by ultrasound or histopathology, will qualify as recurrent pregnancy loss. So those days are gone when you wait for 3 losses. So 2 losses are good enough to trigger an investigation, and a very intense investigation, because no couple deserves to lose a third time if it can be prevented. Genetic causes is a significant contributor, as understood, and evaluation of genetic and chromosomal causes for pregnancy loss do tell us that embryonic chromosomal errors do happen in pregnancy losses up to 60%, but all losses, including sporadic. And parental chromosomal rearrangements happen in 2 to 5% of all recurrent pregnancy losses. With an overview of the genetic causes of pregnancy loss, when we come to sporadic loss, it is embryonic aneuploidy, of course. And I think all consultants are aware that we think of aneuploidy as a sporadic loss, very common being trisomy 16, but then monosomy X, polyploidy, etc., all are common, and the risk increases with the maternal age. Whereas recurrent pregnancy loss has very little to do with maternal age. The genetic causes thereof are very little to do with maternal age. For RPL, mainly it is the copy number variations and aneuploidy, one of the reasons. The second reason is single gene disorder and telomeric deletions, which are a little rare, but single gene disorders definitely are more common. And then we have the parental chromosomal abnormalities. So I will go back to, I will stop the share here and take an input from the experts as to, in their experience, what are the common ones that they are facing. We'll start with Mala and then quickly go on to that. Yeah.
So
What are the common causes you are seeing,
trisomy
genetic causes?
16, yeah, trisomy 16 is quite uniquely more common in RPL, although we are screening all our mothers for trisomy 21, 13, 18. But 16 is one of the chromosomes which is implicated in RPL. But for that matter, any other chromosome and a lot of sex chromosomal abnormalities like Fragile X syndrome are implicated in RPL. We now have more and more of monogenic disorders being surfaced
Hmm.
and parental translocations, and you've got lovely cases lined up. So I think as you present the cases, we will
We
go.
will have more discussion. Can I have one more input from a geneticist, Dr. Pandey? When samples come to you, what do you find more
So
commonly?
yes, madam, most of the time it is usually the involvement of a single chromosome. So as madam has said, trisomy 16, we do see sex chromosome aneuploidy is also surfacing in recurrent pregnancy loss. So usually it's a trisomy or a monosomy of a single chromosome, and usually it is most of the time it is sporadic. It is not inherited.
When
Very
the RPL, the recurrent pregnancy loss samples come, what do you see more commonly? Still, you see aneuploidies more commonly?
Yes,
Mhm.
aneuploidy. So it's at least in 50 to 60% of the cases
You'd
there will
still
be
see. So
yeah.
translocations are less.
Translocations very rare, very rare. And
Are less.
translocations typically will so almost mostly in all first trimester losses, you will have a chromosomal aneuploidy, and about very few percentage, 1 to 2% will have a translocation. It's quite rare.
Fine. Okay. So here, uh, I will just proceed with this. So the best test for evaluation of genetic chromosomal cause for RPL is often, thought of as, in the current perspective, chromosomal microarray. Now, after 2 losses, the best practice is to subject the POC for testing. This is a very golden message that each consultant must take, and one must not hesitate to advocate that. And cost should not come as a constraint. We have to tell them that recurrent pregnancies also have their own cost incurred, about the care which follows for a miscarriage, etc. So
Get a
karyotyping usually fails in the, yes,
comment here.
yeah.
Very often you have patients who are reluctant to
Mm,
pay
mm,
and get the test done
mm,
clinically.
mm.
And I think it is so important for all of us to know that you have the facility of DNA storage,
Okay.
where the lab charges you very little. They will just store the genetic material, don't throw it away, even if they don't pay for it. You can get it stored with a genetic lab, and it's as soon as they get pregnant again, they will come back and say, okay, we are ready now to get that test done, but by that time the opportunity is lost. But if you have stored their DNA, that is a very smart move on the part of the clinician, which gives them the opportunity to run the test at a later date.
Oh, wonderful. That's a very, very wonderful input here.
You
So
want
I
to
think we'll put it in the chat box and we'll put it in the groups to take
yes.
home. It
All
should come
genetic
as a
labs
take home.
will give you
Yeah,
the
it should come. Yeah. So chromosomal microarray is preferred, and I think all the experts here will tell us that it's very vital to pick up unbalanced translocation, submicroscopic deletions, and duplications, which will never be seen on a routine karyotype. Then there are other rare testing or controversial topics, which like inherited thrombophilia, which is not usually done for all. We'll come to it later. It's not a POC testing anyway. Sorry for that. Now, the recommended collection technique is something which I wanted to discuss with the two clinicians. So, can I ask Seema to comment on how exactly you ask the consultants? You tell them to collect the sample for testing. For a microarray, we have to send. How to collect?
Thank you so much, madam,
Mm.
for having me here. So when we want to collect the CMA samples, one is if we are doing it under ultrasound guidance, we should first see if we are taking the fetal pole. Most of the times, the genetic labs feel there is a contamination because we send the placental samples, which they don't want. So one thing is we should be sure that we're taking some amount of fetal sample there.
Mm.
Second, we should not allow the samples to get dry. So many times our labs will report that there was blood clot entangled and they couldn't really see much. So we need to wash it and put the sample immediately in normal saline. Earlier, people used to say you should put gentamicin also along with it, but this is no longer a mandate now. So we can just put it in normal saline, make sure that there is some fetal tissue and transport it to the lab as soon as possible.
So can I just say that we can use a Carmen's cannula and a handheld something like an MVA to suck it out and then put it into a
We
kidney
can.
tray of normal saline? Is it
Important
possible?
thing is that we need to identify the fetal tissue. If the
Okay.
big enough, then we can definitely do that. But if the pregnancy was very small, it is very difficult for us to identify which is a fetal tissue and what is a maternal tissue. In that situation, most of the labs say that you send us all the sample. Don't waste any. Don't just give us a piece for testing. Give us all of it and we will decipher what it is. And along with that, usually we should always make sure that the maternal blood sample has also gone so that they
Mhm.
can compare. And we need to
Fine.
give them all the genetic information and all the information about the couple's detailed history to the lab.
Mhm.
So that,
Family history of anything also,
yes.
whatever. I just wanted to know how exactly do you collect? Do you do a suction evacuation? What do you do?
Yes, we do a suction evacuation and then we filter out. The first
Mm.
is I dilate and then we use an ovum forceps and we take out
Ovum forceps.
the
Yeah, I have
clot.
seen people doing that. Yes.
I do
Mm.
all of them under guidance. So, and we do not curate, we do not use sharp curate. The moment we suck out the pregnancy and we are done with it, we don't have to
We
wait till
don't have to.
that thin
Yes.
layer and we don't want to damage the uterus at all.
very
Yes.
important
Yes.
because the
That's
curate
very
does a lot
important.
of damage to the endometrium.
Correct. Correct. And we must remember here that we are doing a surgical procedure for the sake, in the best interest of evaluation. But otherwise, this
But
pregnancy would have done very well with medical method.
so
So that
now
is
we want to advocate that you can collect, just instruct your patient to collect the products whenever they are passed in a bottle of media or normal saline. You
okay.
don't have to resort to surgical evacuation for product testing. Even
Okay.
if it is flushed, even if it falls into the toilet bowl, she can take it out, put a pair of gloves on, take it out, dry it on a piece of gauze or tissue paper, and still send it. This is the major advantage of chromosomal microarray over karyotype because it's
Excellent.
just a DNA extraction technique. So
Mm.
wherever it gets contaminated, you can still extract the DNA. One important point is don't put it in formalin. So many clinicians will just take out the sample, put it in formalin as we do for histopath, but that will denature the DNA. So it
Excellent.
has to be in normal saline or any special media if
Mm.
your lab provides it.
Mm.
But please don't put it in formalin, and please don't do DNCs or evacuations just for
Okay.
collection.
Okay, that's another good message today. So we shall advocate medical management, and we shall. And so the two good things we have so far learned is the DNA storage, we called it
Yes,
DNA
DNA storage when the
DNA storage, and medical method for termination. Surgical is not always necessary unless there is a failure of the medical method,
exactly.
which often mandates. Yeah. So these two things are very valuable. So let us go for the clinical algorithm now. Two and more losses, POC for CMA. If structural abnormality is found, then parental karyotype will make sense. Counsel and manage accordingly. Well, in any way, I just wanted to run through these few cases in the sense, few examples of what can happen. We test the product and it comes as aneuploid. And this is a 32-year-old, two miscarriages, and the POC shows trisomy 16, as Mala was saying, expected. And we can counsel saying that it is a sporadic. What more can we do here? We'll come to it. Balanced translocation, if you find in the embryo, which has been lost, then go ahead, and if parental karyotyping, if we do, we find that it is abnormal, and then we counsel them for PGT-SR. So we shall come to the PGTs and we can elaborate then. And the case 3 is an unexplained situation. So here, when we look at the product of conception, if it has not yielded anything, like it is neither aneuploid nor it does not show, then we start thinking that is there something beyond CMA, beyond the chromosomal microarray, and then that will fall into the category of unexplained RPL. And even otherwise, when there is a clinically unexplained RPL, will there be a genetic cause even if the CMA is normal? And then we have some answers as further genetic workup, and then we can see what more can be done for such a situation. So I think I will go ahead so that we can discuss more. The parental chromosomal abnormalities may show some balanced translocations, and amongst them, one would be Robertsonian translocation. We may also see some inversions, and the couple is usually phenotypically normal, but they are carriers of these defects. And in the child, it manifests, and it is a non-viable. The pregnancy doesn't continue and it's in a miscarriage recurrently. When to suspect a parental rearrangement like this? Clinically, which patient couples would you suspect that they may be having some problems? When there are recurrent early losses, any of the POCs have shown an abnormal karyotype. If there are family history of miscarriages, and if there is an unexplained RPL, it's always worthwhile doing parental rearrangement testing, because it will help us in guiding for the genetic counseling. I'm so sorry. I'll just go through this slide and then open it for discussion. Well, in general, karyotype of the parent couple, most consultants feel that it is actually of limited prognostic value, but it is still a part of evaluation, but comes as a later on test. So most authorities feel that first you must check the POC, the product of conception, and then only go on to the parent testing if the POC are abnormal. And then we can detect a balanced reciprocal or Robertsonian translocation or even mosaicism, which can be passed to the fetus unbalanced. And this was what was found in 79 published surveys, 8,000 couples. And they found that these couples had major chromosomal abnormalities in 2.9%. That means 5 times more than the general adult population. So the incidence of chromosomal abnormalities is high in these couples as compared to those who do not have RPL, and 50% show balanced amongst them. 25% of them are Robertsonian and 10% sex chromosome mosaicism, inversion, etc. I would like some discussion on karyotype of parent couple. Let us begin with Priya. Priya, can you come in, please?
Hello, ma'am. I hope you can
Priya
see me.
Ranganath? Yeah.
Hello, ma'am. Can you hear?
Yes,
I hope you can see me and hear me.
we
Right,
can
ma'am.
hear you. Yes, please.
So, couple of things I'll just add, ma'am. Why
Mm.
we switched over from karyotype to microarray from the product of conception testing? Not because, I mean, in recurrent pregnancy loss, the resolution doesn't matter. Most of the time, we're looking at aneuploidies only. So, still, why are we switching over? It's because
Why are you tired without doing anything only?
Hello, am I still audible?
Yeah.
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 So the only reason why we're switching over to a microarray is because we can perform microarray even in the dead tissue. Karyotype requires live cells to perform the tissue because we grow it in culture, we multiply it, we do the meiotic segregation, we arrest it at meiotic arrest, and then only see it. So that is the benefit of karyotype, microarray. The second thing we always have to remember is we should do a low resolution microarray, not a high resolution microarray. People think, oh, the more the resolution, the better the answers we get. But in recurrent pregnancy losses, as per international guidelines, only low resolution 350K microarray is the one which is recommended. Third thing about storage of tissue, like Mala ma'am wonderfully put it, absolutely product, dilatation, curettage surgical technique is not at all necessary. In fact, the lesser the technique we get products on call, and many times we're able to differentiate between fetal tissue and placental tissue. That kind of really helps to send the products properly and with minimal damage. So that is also one of the best things to do. And fourthly, coming back to parental translocation. So what's the difference? Generally, people ask me, what's the difference between this balanced translocation and Robertsonian translocation? So when you think of balanced translocation, it's between two chromosomes which are not acrocentric. You have 13, 14, 15, 21, and 22, which are acrocentric chromosomes. That means they have a very short p arm. So if translocation occurs between any of the chromosomes other than these acrocentric chromosomes, then we call this a Robertsonian translocation. Any other than acrocentric chromosomes, we call it balanced translocation. And if it happens in the acrocentric chromosome, we call them Robertsonian translocations. Now, translocations or parental translocations contribute to about 2 to 5% of recurrent pregnancy losses. And in these 2 to 5% pregnancy losses, what's a very good tell is when you do a POC microarray, you'll generally see a microarray where there is a deletion duplication combo between two chromosomes. You will see a deletion of 15 base pairs or 150 MB, which is there in chromosome 22, and a duplication of maybe 300 MB, which is there in chromosome 15. So you know there is a translocation between two things. So that's why RCOG and ACOG shifted from doing parental testing directly to a POC microarray first, identify which chromosomes to look at in the karyotype, because balanced translocations are far harder to find. The resolution is very poor. Cytogenetic skills are much lesser. So that's why this is what is recommended. So this is the basis. Inversion and other structural abnormalities, they have been known to cause RPL, but they're not of very strong prominent value. Mostly balanced translocation and Robertsonian translocation play a role.
Thank you, Priya. That is wonderful. Yes.
Madam, I just want to add one more point here. I also want to add to Dr. Priya's point about doing a microarray, because in my entire career of looking at different cases, I have come across at least two cases where we had identified balanced translocations which were actually submicroscopic. So these were in such small segments of the chromosomes that if a karyotype had been done in the parents, they would appear absolutely normal because it was not visible on a karyotype. But the microarray did show a translocation which was very small, involving about less than 2 MB fragments. And only because of the microarray we could say that this could possibly be coming from the parents, but we had no means of identifying it. We did, in one of the cases, we did end up doing a targeted fish on the parents.
Okay.
Somebody had probes to those regions, and we were able to identify those. So, I mean, very rare, but yes, such cases do exist where translocation could be so small that it would not be picked up on a karyotype.
Thank
Just
you,
to add to
Priyadarshini.
that
Yeah.
point, ma'am, just to add to that point, you're very correct. I have many cases like that too. So what is recommended is spectral fish or an OGM. These are the only ones that can pick up small submicroscopic rearrangements.
Thank you. Mala, anything? Yeah.
Yeah. So many time as a clinician, you get patients who have, I distinctly remember a few who have just biochemical losses. So you're trying to do their IUIs, ARTs, and they will have a beta HCG of 600, 800, and then gone, and no fetal pole. So you don't get any genetic material to test. And of course, so if you have a blighted ovum,
Absolutely.
there is no fetal pole. So then we rely, you're justified in doing parental testing in those cases without a POC analysis. Also, like I'm sure Dr. Seema will agree, sometimes patients will come from periphery after having 3, 4 losses, and none of them have been tested genetically. And now they are with you, and you want to take care of the next pregnancy. So you would want to have as much genetic information as you can. And I'm sure one of the cases will illustrate that to you.
Yes,
And you
correct. Yeah, I just wanted here one input before I share the slides again is we do detect something abnormal in the POC in terms the CMA shows some problem. What will be the next course broadly before we go into the slides which tell us in more detail? As a clinician, when we are sitting, we get a CMA report showing positive. What are the two options that we discuss?
Obviously, as a clinician, you want to do genetic counseling for this couple. If you can decipher the CMA report, like if it is a clear-cut trisomy 21 or something you understand,
Mm.
then obviously you can brief the couple. But there are many instances where the reports need a genetic counselor to decipher it. So
Correct.
my plea is that please do take the help of a clinical geneticist, a genetic counselor. Their knowledge is far more than yours, and they can guide you through your clinical management.
Excellent. Very good. And then the options for further pregnancy can be two ways, isn't it? These are essentially fertile couples. So they
Yeah,
go through a
so
pregnancy and test, or
many
they
ways
go for the
they
embryo
say,
testing. Yeah.
many ways they say that if you find a genetic abnormality, you're lucky. You're lucky because if the parents are not carrying a translocation, this may not recur in a subsequent pregnancy. And the chances of her having a normal pregnancy are much higher than if you have recurrent euploid miscarriages. So if all the products keep testing normal, you are you're being pushed towards very few evidence-based treatment options for this couple. So I think it is important, but also we don't stop at just the genetic testing. You need to do the battery of tests for RPL because genetics could be associated with an anatomical abnormality, a
Yeah.
semen fragmentation issue. So don't just stop at just genetic testing. There are few things you have to test, which includes APLA syndrome, your endocrine workup for thyroid, antithyroid antibodies, your prolactin levels, your autoimmunity testing with anti-nuclear antibody, and looking at the uterus through a 3D
Correct.
ultrasound or
Yes.
a similar modality.
Correct. Correct. So if
And the male
the
partner evaluation as well.
Male partner evaluation, of which the most important is semen analysis, culture, and DNA fragmentation.
yes,
It is a
yes.
battery of tests for
It
this.
is a battery of tests which we have to go through to make sure that we are not missing anything. And in fact, we have to look deeper into the genetic cause to explain the unexplained RPL. Because if all these tests are coming normal, which Mala has just listed out, which we are doing every day for our RPL women, then it is indeed unexplained. Now, couples in whom chromosomal abnormalities are discovered in one or both partners, the abortus is then, or the abortus, they are referred for genetic counseling, as beautifully pointed out by Mala. And we can see the clinical perspective, very strong hold on realities that both our geneticists are having today, Priyadarshini and Priya Ranganath. Probability of having a recurrent abnormal conception in the future is what needs to be considered and discussed with the couple, that what is the chance that the next one also will have the same fate. It can be a miscarriage or a chromosomally abnormal offspring or a phenotypically normal or abnormal individual. These are the options which have to be discussed. What is the probability of this? And that is why you need a geneticist, because this kind of detailing a clinician will not have knowledge about to this extent. The risks depends on the specific chromosomal abnormality and the sex of the carrier parent. So it may differ whether the mother is carrying it or father is carrying it, and what is the specific abnormality or the defect. Couples with abnormality can undergo prenatal genetic studies. That means they can go for a spontaneous conception because their problem is not conceiving. So they conceive easily, they're fertile couple, and once they conceive, they can go for amniocentesis CVS to determine the fetal karyotype and testing on the tissue, and then go for pregnancy termination if the fetus is affected. That is one possibility. Now, another possibility, Mala has pointed out that they can store this DNA also if at this point of time they cannot kind of, afford it, etc. But then those couples who can afford can plan for embryo testing through pre-implantation genetic testing. And this will be discussed today because this is a knowledge gap that we have. And it can be used to ensure transfer of a non-affected embryo. That is so that the tragedy of loss is again not there and it is fruitful. Depending on the specific abnormality, other options which emerge, suppose these are not working for the couple, in the end, of course, gamete donation is also a possibility. Surrogacy and adoption is also a possibility. Always in cases of RPL, so many other complex situations can be there which can push us towards these solutions. But as far as genetics is concerned, this is how we dig in. So once we decide on PGT, then we have four types of PGT, and of course, it's the blastocyst, which is biopsied, or the polar bodies, etc. Right, and then the selected fresh frozen thawed embryos are then transferred. But the thing is, as mandatorily, the couple has to go through the IVF cycle. A fertile couple has to go through the expense and the risks and of an IVF cycle. That is the requirement. Now, PGT can be for aneuploidy, can you be for a single gene disorder where it is called monogenic PGTM, or it could be for a polygenic disorder, which is so far is not much in clinical practice because it is essentially for adult disease prevention. So maybe we should not discuss that. But then what clinicians must have encountered is PGT for structural arrangement. That is, whenever you find a unbalanced translocation and the couple is having a balanced translocation, then there is a setting for PGT-SR, structural chromosomal abnormality. Okay. And then there is another one which is known as PGT-HLA, about which there is a case. And IVF is done, and risks and expenses limit the utilization of this technology. I would again want to throw the question to the experts to discuss a bit about their experience with PGT so far. Yeah, so that consultants get a grip of ground level realities. Yes. Yeah.
The success rate of IVF is a limiting factor. And so far, most literature says that if they try normally, they will have a similar success rate than if you put them through this huge financial and emotional journey of doing an IVF and PGT. However, the good news is that the time to pregnancy gets shortened with IVF and PGT. So if they're trying normally, they will have another miscarriage, maybe another miscarriage, and then go on to have a live baby. But if you're doing this procedure, you are selecting a good embryo, then the time to pregnancy is shortened and they don't go through the trauma of having miscarriages in between. Now, as our biopsy techniques, the time when we did a day 3 embryo biopsy was very traumatic to the embryo. These days, we all do the biopsy after there's a trophoblast, and we only take the trophectoderm cells. And people are working on doing cell free DNA testing on the media around the embryo It has not yet come to clinical practice, it's still under research. But once that comes in, then this procedure is going to be more popular, because then you're not damaging the embryo, you're just testing the media in which the embryo was stored, into which the cell-free DNA has leaked. And that will be perhaps the day we will have more and more people opting out for IVF.
Correct.
But as of now, I think for us in India, the financial condition of the couple is a huge constraint. And I think you cannot pass the verdict of doing IVF in a fertile couple just for this gain. So you need to counsel the patient with everything,
Correct.
let them take what suits them best.
Seema, anything?
Yes, I have not found particularly much success with PGD. I mean, I send my couple sometimes for IVF, but eventually, I think what ma'am is saying is absolutely the right thing. When they conceive on their own as well, I think the success rate is comparable eventually. Yeah, it may take longer, but yes, people who are conceiving on their own, I think they're best left onto themselves.
No, but then the question will come, then what all this testing that we do, to what avail it is? Is it only to counsel and to tell
No,
them about the prognosis? Yeah,
depends on the maternal age a lot. So if the mother is of age 35 plus and her time is running short, then there makes more sense for her to have a tested embryo
yeah,
transplant. If she's in her 20s and she has plenty of time, there's no point in pushing her for IVF and PGT.
correct, correct. May this become different if it is not unbalanced translocation, but it is a single gene defect? Will this approach be different? Then will we be kind of wanting to do
We have
PGTM?
identified the gene, then of course it is less traumatic for you to test the embryo for that defect. And just like we do for sickle cell, it is so important that we transfer the right kind of embryos.
Okay.
It will definitely make sense. But for very complex inheritance, I would like Priyadarshini to contribute to
Yeah.
on
Yes, Priyadarshini, please. And Priya.
So I think that as ma'am has said, that once we have identified a genetic abnormality,
Mm.
which is either a structural chromosomal defect or a single gene disorder, in my opinion, the patient should always be given a choice about IVF, because we know what
Yes,
we are looking
I
for.
agree
I
with you.
don't
Yes,
necessarily think that PGTA, which is done just for aneuploidy screening, should be offered to almost everyone, because that as the data shows, it doesn't make any. I mean, the live birth rate is not affected with or without doing PGTA. But yes, if an abnormality is identified and the parents have already suffered, a few times with an affected child or whatever it
that's
is,
what I meant.
then
If
then
PGTM may have a more
yes,
robust,
even SR, madam, because SR
even
is
SR.
also, you know what you're looking for. There is,
Mm,
and the inheritance is same as a monogenic disorder. So
correct.
it is a chromosomal abnormality that is being inherited, and the odds of it
Yeah.
need to be explained to the parents. Yeah.
Priya can give any input here.
Yes, ma'am. So two things. Once, when we are checking the once parental translocation has been identified, we're not just doing testing for the fetus to understand aneuploidies, but now because they have balanced translocations, these things can totally differ. So we have to do a microarray in the CVS or amniocentesis sample and not a karyotype, because submicroscopic deletions then become more common. So it's always that.
That is
Then
taken. Yes.
coming to
Mm,
the second point about PGTA
mm,
versus this, I do agree that
mm,
PGT-SR, which is going to map exactly where the breakpoints are for the
mm,
parents,
mm,
will, with aneuploidy, which is basic screening, so with all of that genome-wide screening, not basic, so
mm,
will probably increase the choice of the embryo, the option for the embryo, taking age and other things into parameters. but they will also conceive on their own. And if they have time with them and they have the patience to understand that this could eventually happen for them,
Yeah.
then obviously they can conceive naturally.
Yeah.
But all natural pregnancies should undergo microarray, should and
Correct.
must. That is no
Yeah.
doubt about it,
So,
because most of these end up as children with
mm,
microdeletion syndromes,
correct.
which we see most
So,
commonly.
let me.
Ma'am, quickly one point. So there are some, chromosomal rearrangement. So if you have a 21-21 translocation, for example, so this kind of translocation,
100%.
yes, it's 100%. So if you
100%.
don't, I mean, they will never have a live baby. So
Never
in
have
these
a life.
cases,
Mm.
so in these cases, it's so important because they will have to go for a donor
Yes.
donor gamete.
That's a
And I think
lovely
that,
message.
yes,
Yes.
so I just think that that counseling is so important
And
for,
it's the type of defect which will also guide you towards whether you should offer the
yes,
PGT or not. Yeah.
yes.
So that is where we need the geneticist to come in.
And
Once
also,
you
just a
identify.
note about the monogenic disorders. The
Mm.
monogenic disorders causing these definitely do come up with some phenotypic abnormality.
Yes.
Either they are early ciliopathy defects or lethal skeletal dysplasia, which has
Correct.
come up much
Yes.
early. So here
Yes,
you have a
Priya.
strong family history,
Very
everything else.
nice. Correct.
You have to be
You have
very
brought that up,
careful.
and there are cases corresponding to that. So we will quickly discuss that. I just wanted to share here, Mala, a couple whom I have treated. Two of them actually. One couple had a protein S deficiency children who kept on, passing off at the age of 1.5 years. It's a consanguineous couple. They lost two boys like that at the
Yes.
age of 1.5 years. And the
Yes.
third time she became pregnant, and we sent her to Vellore because it was not available with us with the advanced genetic testing. That time they were not calling it microarray. It was advanced genetic testing, and they said that this particular child is unaffected. And
Right.
then they went on to have a normal child. Another couple, as correctly as Priyadarshini and Seema both have told, that they can go on conceiving, and the clinician's role becomes to support them through those miscarriages. We kind of become very tender loving for the miscarriages itself. We encourage them to go on conceiving. And one such couple could not afford anything else. They could not even afford testing. And I was working in a mission hospital at that time. And the fifth miscarriage which she had, we
Mhm.
encouraged her to adopt because we felt that that will help her.
Yes.
After that, she had one more miscarriage. She was bringing up the adopted child also. And then she had a successful pregnancy, finally, the seventh. So these stories are there in the past, but today couples need not go through that, intense suffering, because I think it's a grief which is seldom acknowledged, the grief of miscarriage. Just
Yeah.
like stillbirth, it is
Point
something
that
which we do not. Yeah.
we want to
So,
make for the
yeah,
audience is that
yeah.
protein deficiency, especially if it is in both partners,
Hmm.
leads to late pregnancy complications like sudden unexpected IUD, stillbirth, or neonatal death. So it is rarely the miscarriage part, but it can cause late pregnancy complications.
Late and neonatal process.
And
Yes.
you need to test these couples, and they need to be anticoagulated right from the
Yes.
start of their pregnancy to improve.
Correct. We did that also in her.
Even
Yeah, we did that. I was
one
did
such
not
couple,
mention it. Yeah.
in
Correct.
spite of
Correct.
anticoagulation, we had to rush in at 34 weeks. There was
Mm.
severe fetal bradycardia, just picked up on random ultrasound, and then we could save the baby who lived in ICU for a month. But this protein S deficiency has to be very seriously managed
Mm.
in the antenatal period.
Yes. 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 The child doesn't have a
Can
life
I just
actually.
ask
They
a
develop
question?
thrombosis and
Can I
soon
just
they
ask
develop complications.
here?
So can I ask uh, somebody to mute? Yeah. So
No, no,
then,
no. Can I ask a question if you don't mind?
tell me, Pragya. Yeah, tell
Yeah,
me.
yeah.
Yeah.
No, no, since Dr. Mala Arora brought up this, about IUDs and all that, like
Yeah.
I've had a few patients where, the mother had chromosome inversion between chromosome 11 and 6, and so this, I mean, and there was a history of two IUDs in that patient.
हाँ
So,
क्या
but now, of course,
वो तो मुझे तो कहा नहीं है छुट्टी से बना कर खाओ ना कुछ
So I did,
क्या है?
when I did amniocentesis, I had to do amniocentesis after that, when she came to me already with the history of two IUDs.
दिया तो बताया होगा ना,
So, and the amniocentesis
रूट
report
वगैरह सारा.
back as normal.
Yeah.
And
हाँ,
and now again she's conceived. This is
मीठो
her
है
second
इसमें.
time. This time again I've done an
और स्ट्रॉबेरी.
amniocentesis. This
Yeah.
Can
was
I
gel.
request everybody to mute, please? Yeah, thank you. Yeah, yes, please.
So what I wanted to ask, as someone said, that in this case, I already knew what the mother's genetic problem was. So in that, when I did the amniocentesis, actually I did not send for a CMA. I only sent for a karyotyping. So was I justified? I mean, because someone said that then
Yeah,
if
it should be CMA. Yes, Pragya, it should be CMA. I agree with Priya.
Now you can ask for, yeah, I think amniocentesis or CVS or NIPT, but once you know what you're looking for, I think you can do a specific QF-PCR for that deletion,
PCR.
which is cheaper.
Hmm.
Once there's an identified cause, it becomes so much easier for the geneticist to identify in the fetus.
Just to come in there, ma'am. So you had a protein C deficiency which you wanted to check in, isn't it, in the fetus? So
Yeah.
there the testing is Sanger. So you'll do a Sanger sequencing where the variant is identified and that particular variant itself will be tested for that.
That's correct. Yeah, so I will just move ahead with this kind of outcome of IVF and PGT and the studies which have been done thereof, and which all the experts shared that there are mixed results, and the cost involved is a little bit kind of a limiting factor for us. So the embryos of women with unexplained RPL have a higher incidence of aneuploidy for chromosomes this many, and then embryos obtained from healthy women. So aneuploidy is an inherent nature of embryos from RPL pregnancies. And in a retrospective cohort of 300 women with RPL, actually, the pregnancy, live birth, and miscarriage rates were similar for women who underwent IVF with PGS and women who elected expectant management. So this particular cohort showed 168 retrievals, 38 cycles actually, and cancellations of 38 cycles, that is 23%, because of poor embryo yield and quality. And this is because, as I have said, that there is an inherent nature of high aneuploidy in these embryos. So the yield might itself be poor when you go ahead and do IVF for them amongst the retrievals. There were, however, 130 completed PGS cycles, and 74% actually yielded one euploid embryo. So at least one euploid embryo. So you may get one normal embryo only. So limited number of normal embryos are obtained. So that is what. So it is a little guarded decision, but it is one choice that the couple can have to have IVF, and we have been presenting cases now which show this kind of pathway which the couples have taken, because the cases have been that severe. So this is 32, 35 years couple, professionals, 5 abortions. This is a case, I think this was shared by Dr. Seema and Dr. Mala Arora. So this is all spontaneous miscarriages throughout, and the POC tested is actually normal, and it was tested once and it was normal, and once CMA, and I think once karyotype, I think. And uh, the ultrasound was normal, bloods were normal. And then the parental karyotype, this one, yes?
Yeah,
Yes,
maybe Dr. Seema
right.
can tell us.
Yeah, Seema? Yeah.
Yeah, this couple had come to me already just after the fifth miscarriage to take a
Yeah.
second opinion.
Mm.
No CMA was ever done. They just was karyotype was done, which yielded nothing. So when we went back and did all the investigations. So the structural abnormalities were not there, sugars and everything else was normal. This was a very, very busy couple. So, we did all the investigations at the same time, young, normal BMI couple. So we did find a balanced translocation between the long arm of chromosome 1 and 3 had interchanged. The husband was normal. So once we identified that there was a balanced translocation, I sent them for genetic counseling. And our genetic counselor advised an IVF with PGD-SR because they were quite fed up and they had 5 miscarriages. And the age was also, they felt they'd been married now 7 years, so they wanted to conceive.
Yeah, correct. And the picture on the right side is the fetal karyotype report. Do you want to say anything?
It's a mother's karyotype.
It's a mother's karyotype.
We can,
Okay, final karyotype report. Okay.
So
That is the one showing the
yes,
abnormality. Yeah,
yes.
correct.
So this was the picture, and then this was one
The
couple.
translocation. The arrows are showing. These
Yes.
arrows are showing the translocation, right? The balanced translocation. Yeah. So here I wanted to bring out a point, Seema, as you're saying, that here the POC is not available. POC testing is not available.
Yes.
But the number of abortions are multiple and there is no other cause.
But
So,
from the parents' perspective, they did test twice.
that's what. Yeah.
And,
They did test, but it was not available for you, maybe, and it was reported normal, right?
Yes.
And CMA was not done. So this is a situation where even though the POC testing is not available, still we have subjected the parents to karyotype. So it can come in as a later test in case this kind of deficiency is there in the workup. So that is another message which you can give. And here you have hit the jackpot, and you did get an abnormality, and some solution has come from that. Yeah.
In my practice, I haven't really found very few people, I think couple
So
only.
did this patient go ahead with the IVF?
Yes.
Okay. Did she get a healthy baby?
No.
Pardon?
She hasn't gotten pregnant yet. This is a case, she was conceiving soon by herself. So I told them, I said, the choice is yours, whether you want to conceive, and, but we didn't really find anything else. So,
Okay,
PGD-SR.
let me move past this. This is a case shared by a colleague of mine who is practicing IVF in Bangalore. I hope she has joined. Dr. Rekha, I hope you have joined. I remember sharing it to you. Okay, let me.
Yes, ma'am. I am here, ma'am.
Rekha Vishwanath is here. Good. So, Rekha, this was your case.
Good evening.
Yeah. Good evening. Good evening. So, this is a case where you found repeated missed abortion, blighted ovum, and then you found in the third natural pregnancy, you did find that there was a trisomy 21, right? In the third pregnancy.
Yeah, ma'am. They underwent amniocentesis in that pregnancy.
Yeah. So fish trisomy 21, and in the family history, the mother had 2 abortions. So this is a little rare case where there's a trisomy in one of the pregnancies, but obviously the other losses are explained by something else, right? Because then when you have done the karyotype couple, you have found this kind of Robertsonian translocation. So over to you, and you can talk a few minutes. Yes, please. Yeah.
Yeah, so hi everyone, I am Dr. Rekha Vishnath. I am a fertility specialist working in Oasis Fertility in Bangalore, HSR layout. So this was just an interesting case which I shared with Dr. Shobha. This was a couple who came to us like after 10 years of marriage with history of 3 abortions as mentioned here. And they did
Can
not
we
do
take
any...
it up from the karyotype of the couple? Can we take it up from here, please?
Yeah, so the karyotype showed this Robertsonian translocation between chromosome 13 and 21 as shown, and the husband's karyotype was normal. So we send them for a pre-PGD workup, and the geneticist had advised IVF with PGT for structural rearrangements. And we through IVF, we got 3 blastocysts from the patient. And we could identify 1 embryo with balanced euploid, which was a balanced euploid embryo, which was suitable for the transfer. We are yet to do the transfer, and the other 2 actually came as an unbalanced monosomy 21. So this is the only single balanced embryo which we got, and probably we will get a successful pregnancy with that one.
Yeah, let me hope so. Yeah, I just wanted to bring this because Dr. Priya Ranganath is there. Yeah.
Yes, ma'am.
Priya, can you just decipher this Robertsonian translocation? Yeah.
So, what is Robertsonian is the P arm of both 13 and 21 chromosome. They are lost because they're very small. They hardly contain any genes. So, they're lost. And the two Q arms, the long arms of the chromosomes, they come, join each other, and they form a single chromosome. So, that is why you get this Robertsonian 1321. So, mind you, this is common, and we do get multiple Robertsonian translocations. If it is between 21, that's what we have to rightly check. If it is between 21, yes, there is a donor only option. Whereas if it's between any other, we have seen that the success rate is very good. About 70% is with natural pregnancy also, you can conceive. And about 30 to 40%, you have abnormal gametes coming up with it. So that's the idea behind this translocation.
Yeah, because in this PGT-SR effort which was done, there is a
Yes.
30% normal, right? Amongst the 3 embryos, 1 is normal.
Yeah. Yeah, but because we have tested only 3, so
Hmm.
generally the percentage is
Okay,
about
fine.
60 are good,
Okay,
but
okay. So
we do
naturally also they would have, but
they
here,
would have,
okay.
but testing again is very late. So
Correct,
whether they're
correct.
okay and all of that is still a
Hmm.
question.
Well, here the couple repeatedly had problems and one downs also. So probably everything we do is justified. But yeah, so the couple karyotype did show abnormality, and the options are natural conception and testing or IVF and PGT-SR. So the couple has opted for PGT-SR here. So then I think Dr. Mala was also agreeing with me that we should have some kind of guideline comparison because there are so many people talking so many things, I mean, different definitions. So we thought we will check in ASRM, ACOG, ESHRE, RCOG, etc., and see how they define RPL and how they think about the causes, etc. So the definition of RPL 2 and more than 2 is ASRM, ACOG, ESHRE. RCOG is sticking on traditionally to 3, but I'm feeling that soon they will also change to 2. POC testing recommended by all. Genetic testing of POC is recommended by all. Once the couple loses 2 or more, please remember, dear consultants, that once the second loss happens without any other major problem, obvious problem, please subject this very second loss to genetic testing. The preferred testing is CMA, and it is, it is composite genomic hybridization or single nucleotide polymorphism. I promised myself that I'll become good in expansion of all this because it's high time even clinicians talk this language so that patients develop more confidence in these procedures. And this array over conventional karyotype, we have to do this because it will pick up all this. We have discussed this earlier. And if abnormal POC, please do parental karyotype, or if unexplained RPL, also please do parental karyotype. Inherited thrombophilia is not recommended as routine in all of them, only if there are indicators for it in the couple, in the maternal history, etc. PGT-A is not routinely recommended. Everybody agreed to that just now. PGT-SR is recommended for structural rearrangement carriers, as we saw the cases. Okay, so I think the key differences are 2 versus 3 losses. CMA preferred, but access and cost vary globally. But today, I think the cost is coming down. In a minute, I'll ask about the cost. Routine thrombophilia testing discouraged. PGTA improves time to pregnancy, as Dr. Mala very rightly pointed out, but not always cumulative live birth. And importance of individualized counseling cannot be emphasized enough. So I think before we go on to the single gene defects, which is the last part of our discussion, can I just discuss a little bit about the cost of testing? Yeah.
So let's ask the genetic people to answer this question.
Yeah, please. Yes. प्रियदर्शिनी, आप कॉस्ट के बारे में आप क्या कहते हैं? Unmute.
Yeah.
Yeah.
So I'm from a commercial organization, so I'm not sure. But see, I'll tell you that whatever we call it, the MRP of these tests is anywhere between I would say 18 to 20,000 rupees, and they give handsome discounts onto this price. So I think
You're talking about
micro
no,
array.
you're talking about Mumbai, no, the city of Mumbai. Yeah,
Yeah, I
micro
mean,
area.
I think the MRP remains constant across all cities. But the thing I'm trying to say is that an average RPL microarray workup should cost generally the cost comes out anywhere between 10 to 15,000 rupees. This is what my estimate is. I'm not sure. I mean, there might be lower prices also on the market, but this is on an average. This is what
Priya, you agree? Priya agrees?
Yes, ma'am. We can get it done as less as 8. So it's
As
depending
less
on
as
how you bargain. But
oh.
8 to 10 is generally
I'm
what my
so happy
micro.
because she's practices in the same city as I do. So that is good for me. Yeah, Rekha, you want to say anything? I would like to ask Seema what is also. Yeah. Rekha, what happens in your center? Same?
The cost, ma'am, you are asking?
Cost only.
Cost on the micro array, yes, ma'am, around 18 to 20,000, ma'am. That is the charge here
Okay.
on the products
Okay.
of country.
So there is a differential between you and Priya. Just watchful.
That is
Seema?
that is how you bargain with the the labs. So
So
labs have a margin.
generally corporate
Yeah,
rates tend to be higher, but
higher.
I
Okay.
think
Yes.
if you are sending it directly to the company, it might
Mm.
be cheaper.
Yeah. Yeah, that is a
I
point
agree
there. Yes.
completely. So the
Okay,
cost to the
Shobha,
lab
um,
should be as low as
Yes, ma'am.
8,000. Yeah.
Mm.
Dr.
Somebody is
Shobha,
asked. Yeah.
yeah, yeah,
Uh-huh.
yes, but recently, I think it's LifeCell, or I did not want to mention,
Mm.
they are giving quite a lot of discount, when you do both together,
Both
karyotyping,
means?
karyotyping and chromosomal microarray together.
Oh.
And yeah, and
I didn't
especially
know that is needed. Is it Pragya?
no,
I,
no, because see, for balanced translocations, we have to go for
Acha,
karyotyping.
you're meaning parental karyotyping
Yeah,
and
yeah, yeah.
POC
No, no,
microarray.
as you know, I said that, in my practice, most of my patients, if like I've picked up some problem in the mother or the father, it's
Acha.
most of the times it's like a balanced translocation. So, I mean, initially, I know RCOG and all, they all say go for products of conception,
Yeah.
but that
Okay.
works out to be pretty expensive. So, I usually go for parental karyotyping, and the cost has really come down for
Okay.
karyotyping plus chromosomal microarray
बहुत
these days.
अच्छा. Yeah. So we'll go ahead with the single gene defects in RPL and
Just to
when to.
come in, just to come in prior to that, ma'am. So most
Yeah.
of the parents will have only balanced translocations.
Yeah.
So doing a microarray may not yield a lot. I mean,
Mm.
the labs are taking advantage of you, ma'am. So
Yeah.
you can
Yeah.
discuss that with
Yes,
them. That's
yes, yes. So when to suspect monogenic causes in RPL is, I think the experts will agree when there is similar gestational age losses and recurrent structure fetal anomalies which are similar. And if there is a consanguinity thrown in, definitely it could be a single gene defect. And if there is a family history of neonatal death, so our history taking has to actually look at pregnancy losses in the family as well, which we are not routinely doing. But the moment we get pregnancy loss, probably it's wiser to add on to the family history and check about the reproductive losses in the family. Normal parental karyotype, if it is there, and a euploid POC, if it is there. So this sets the background for a single gene defect. That means the cause is genetic, but everything is coming normal so far. So then look for a single gene defect. So this is a kind of flow chart which I was able to get, and I think, what do you say, Dr. Priyadarshini, on this flow chart? Um, do you think
And
this is the kind of flow chart you follow?
So it says over here, two losses perform POC CMA. That's the guideline. That's fine. And if the yeah, so I think the monogenic testing, the biggest clue that you need to have is that you have to see a structural fetal abnormality, right? Which is to some extent indicative of a particular loss, or a particular genetic condition. And oftentimes, what I feel is that before proceeding or before deciding whether it is a monogenic condition, a genetic consult is extremely important. Nowadays there is a very, everybody wants to do a whole exome sequencing on POC and any such test, right? So I feel that instead of just, it would save a lot of time and effort from on the labs
And
part
money.
also, and
Mm.
money also. If a proper genetic consult is done, one other thing which is not, I mean, I think I don't know whether it's mentioned on some other slide, but if it is a structurally abnormal fetus, if
Yeah, it is
possible,
there here. I
yeah.
told
No,
in
but
the
I'm
previous
saying,
slide also,
but I'm
recurrent
saying,
anomalies which are similar in
yeah.
the.
But ma'am, what I'm saying is that a
Mm,
fetal autopsy,
mm,
that also
okay.
becomes important in many
Mm,
cases because, for example, if it's a skeletal abnormality, and
mm, mm,
X-ray can sometimes actually tell us what kind of a skeletal abnormality it could be. So
okay.
you have a provisional diagnosis even before you do a
The
sort of,
WES.
yes, even
So
before
what
you
is
do any kind of.
WES and how much does it cost in your setup?
So WES is whole exome sequencing. Whole exome sequencing roughly covers about 20,000 plus genes,
Mm,
which are looked at with respect to the fetal abnormality. And this is the most comprehensive test,
okay. Mm,
which gives you the clinically relevant information.
okay. Okay.
And the cost, again, I would say same ballpark as a microarray. I mean, probably a little bit
Okay.
more, around 15K or something like
Okay, we'll
that.
accept that because here also I've come across 15 to 20K.
Yeah, yeah.
So what the message we wanted to give here is consanguineous couple, POCs are normal on CMA, phenotype of the previous children are abnormal or similar fetal terminations for similar kind of malformations, and family history, all this is putting in the context for monogenic causes or single gene defects. And to give the audience a few examples of this, because we have been taught in our medical, the education that single gene defects are autosomal dominant or autosomal recessive. So since here the couple walks in, as normal looking couple, even if they are autosomal dominant single gene defect, possibly it is a parental mosaicism which is allowing them to be phenotypically looking normal. Autosomal recessive is the most common one which we encounter, especially in a consanguineous marriage, and it results in RPL. We think of this. This again we have been taught in our medical schooling. What is a little rare is our X-linked disorders. We see recurrently the male fetuses being lost. Then we think of an X-linked disorder. The diagnostic approach, as Priyadarshini just said, is CMA first, POC. After that, if there is a phenotype which is known and is corresponding to a particular genetic defect, then we can have a targeted genetic gene panel and we can have a WES. And there is something called trio sequencing which improves the yield. So that is how we stepwise approaches there. And I have already highlighted how to reach to the conclusion clinically that it is monogenic, but targeted counseling will improve the outcomes. And normal CMA does not exclude single gene disorder. So the clinicians should never feel cheated that we did a CMA, but we did not pick up a genetic cause. And look here, the next class is also looking like a genetic. So it does mean that there is a single gene defect and further testing. So what is WES and trio sequencing? Would you like to tell the audience?
Ma'am, are you asking me?
Yeah.
Yes, Priya, go
Yeah,
ahead.
yeah. So, targeted sequencing is, so for example, if you identify a skeletal abnormality in a fetus, right? You
Mm,
know that it is some kind of a skeletal dysplasia, or if you
mm.
identify, for example, cystic kidneys in the fetus,
Yeah,
right?
yeah.
So that is also again a very targeted finding. So
Mm,
one could opt for a like a normal panel which just looks at all nephrological conditions.
mm.
That could be a targeted panel. In case of skeletal dysplasias,
That
there
saves
are
cost, no? That saves cost.
not really, not really.
Oh,
So
mhm.
I mean, I don't think that I am not a proponent of targeted panels.
Then you would like to do WES and trio-sequencing?
Yes.
I
So
mean, let us
WES,
just give
yes.
off a clear
So
message. Otherwise,
it all depends, madam.
mm,
Here we are talking about testing on a POC. So
okay.
if there is no if the affordability is low, I mean if
Mm,
because
okay.
trio will be three samples, doing WES on three
Okay.
samples will three
Okay.
times be the cost will be three times. Whereas in POC, we are not fighting for time, so we can just look at the POC sample first. We can try to identify a common genetic cause, and if we identify one, then we can go ahead and test the parents. But however, having said that, if we are doing amniotic fluid testing, and because the time is limited, we always invariably advise for a trio testing where we test
Okay.
mother,
Fine.
father,
Got the
and
message. Got the message. You cannot beat around the bush when there is an ongoing pregnancy. You
yes.
need to quickly diagnose whether it is normal or abnormal and then do a trio. So, trio is further amplification of WES because you have to enlighten
No,
us.
no, trio is where you do the fetus and the parents together so that you can
Oh, that is
establish
trio.
whether
Oh,
the,
simple as trio. Good.
yes, where you can establish
It's
whether
nice, Mala. Okay,
disorder
very
is
nice.
inherited or not.
Whether it is inherited or not. Excellent, excellent. Very good. So there are simple examples of SGD, single gene defects for the audience, that they are musculoskeletal ones. And I think Priya Ranganath, if you have any input, please give here, stop me and give here. Musculoskeletal defects, which are autosomal, yes. See, this, do you remember reading in MBBS myotonic dystrophy, thanatophoric dysplasia, type 2 osteogenesis imperfecta? All this used to come as autosomal dominant disorders, and they are principally musculoskeletal defects. And I think they are very obvious in children. So then we can test for that. Genetic, yeah. Tell me, Priya.
So, just to come back to that, as Dr. Priyadarshini also mentioned and
Mm,
mentioned very rightly, that definitely we need to have a phenotype
mm,
before jumping in and doing a whole exome sequencing. So, when you do a whole exome sequencing, 50, 60,000 variants come up, and many of these are variants of uncertain significance. So, VUSs. So, unless you know exactly what you're looking for, which disorder that you're looking at, which ballpark you're looking at, it's very difficult to interpret a whole exome sequencing, and it
thank
has
you
a
so
lot of
much for that.
interpretation
Yeah,
challenges. So we have to be
very
very,
nice.
very specific. And on isolated pregnancy losses without phenotype, doing a whole exome is done, but it's done
Mm,
only in research setting and not in with us where there is no specific family history. That's a very important message. I find so many whole exome sequencing coming up to me after recurrent pregnancy losses. We really will not be able to add value when it's just a VUS. And they have done a very important or a big test, but we're not giving you any answers. So the patients are also very desperate at that point of time. So
mm.
we have to offer these tests sparingly and with the right intent.
Yeah. So then this is exactly, this case is proving your point. It is 28-year-old, three second trimester losses in a consanguineous marriage. And NTDs were major neural tube defects and limb deformities. So there you have the phenotype. And the POC CMA was normal in the prior loss. And the next step, of course, is a trio WES. And the interpretation of results is autosomal recessive mutation is identified, and the couple is told that there's a 25% recurrence risk, which is very correct. And then the management options are, again, as we said, and here I think Mala correctly brought in these details. She told me it is either pre-implantation genetic testing, PGTM, or the couple has to go for yet another spontaneous conception, but this time go for NIPT. and prenatal diagnosis with CVS or amniocentesis and testing, and early anomaly scan in natural conception. This all has to be done for the pregnancy. And IPT will give us some information. Yes. Yes,
Expand.
Mala. Yes. Expanded NIPT. We will come to that. And then the IVF option, the PGTM counseling has to be very clear that 25% recurrence will be there, and the process and the cost and the limitations, the emotional financial considerations, everything. We have gone through this in this webinar. We have already gone through this. So let me,
the message you want to give, Shobha, is that a lot of people who are carrying autosomal recessive defects,
yeah,
it's a 25% inheritance, so there will be normal children born if we just wait.
correct.
If the disorder is just ending in a miscarriage and not producing a disabled child.
Yes.
So I have had many couples where we have identified something in the parents and then found that after a couple of miscarriages, they go on to have a normal pregnancy because there's natural autocorrection or selection of the gamete that is normal. Nature also
Yes.
wants to
Nature also is kind. Yeah.
and so there is hope even if they don't afford any of this testing.
Beautiful message. That's what the obstetrician role becomes, then how best you can take them through those losses and how best you manage their grief. So this was again, I think, shared by Rekha Vishwanath, 37, 38-year-old, consanguineous, first child, Fanconi's anemia. So this is a, the phenotype is absent thumb, etc., atrial septal defect, hydronephrosis, growth deficiency, hypothyroidism, etc. Now the couple is planning for a second pregnancy, and this is where the genetic assessment, etc., comes up. And they want a match for the affected child because they want to try the hematopoietic stem cell transfusion from the unaffected sibling for the affected sibling. So they want the siblings healthy bone marrow or cord blood, and therefore they have planned for something called PGD HLA typing. So this is another way in which one can help couples who have affected children. And anyone wants to say anything on this? Because Rekha, would you like to say anything?
Yes, ma'am. It can help in the treatment of the affected child, ma'am. That is the main.
Sampath, webinar alidini.
So this was
So
one
I'll
case where
call
we
you
could
back.
help
I'll call you back,
the couple
provided
to
your
finding
phone is
the
not
proper
busy.
match.
Here I wanted to ask because these two blastocyst embryos are
Yeah, ma'am.
carriers of this variant, but they're not
Yes,
affected.
ma'am.
So
Yeah, they are not affected.
is that good prognosis for these two carriers of Fanconi anemia?
Yeah, both the wife and the husband were actually carriers, ma'am. In them, the
No, would you still select and implant the blastocyst, which is a carrier but not affected?
because we got only these two blasts, ma'am. Both were carriers, and I think she was a case of poor ovarian reserve only. So we could get only these two embryos from her, and one of them was not HLA matched, ma'am. Both were carriers. One was not HLA matched, one was HLA matched. So we went ahead with we explained to the couple, and we went ahead with the transfer of the carrier and HLA matched.
Correct.
Probably they will, when the child becomes an adult, probably during the time they are planning their family, they will have to undergo this IVF probably, and
So
avoid
whether this
consanguineous
child
marriage.
will be able to support the sibling, whether that can happen,
Uh,
Mala, or can Priya tell us
My
whether
question is whether
hematopoietic stem cell transfusion can help? Yeah.
sure they will be able to get the stem cells, but my
Mm.
question is, what is the prognosis for a carrier child?
Mm.
Is she healthy, or does she lead a healthy life, or would she develop because they have defects of DNA repair, right?
Mm. Correct.
Ma'am, both
Wo-
the parents were actually carriers now.
Mhm.
Right, but
Both parents were carriers.
they are normal.
Just to come in on that, the
Yeah.
Fanconi anemia has certain genes, like you rightly mentioned, ma'am, on the DNA repair defect scheme. Now, some of these genes, they are known to cause or predispose towards cancer, adult onset cancers.
Right.
Now, and there is a strong association between them. They don't cause
Correct.
fanconi in the
Acute
parent or
myeloid
carrier.
leukemia. Yeah.
Yes, yes. So that is
So
what is the concern here. But
that is
these are
what
also
was
again,
my concern.
yeah. But these are also very gene specific, like Fanca A does not have this association, whereas Fanc C and others may have closer association for breast
Correct.
cancers and others.
Correct.
So knowing which gene, what is the penetrance to adult onset cancer could also help us to determine which embryo we choose
Yeah.
at that point.
So obviously, there is a lot of hidden facts in the sense, a lot of things here to understand. And, because sometimes when assisted reproductive technology is used, there can be a lot of ethical considerations around it. And I think that was well brought out. But anyway, this couple also is a carrier and they may have a
And
solution. Yeah.
also for me, the consent of the child to be a bone marrow donor for another child, which would
That
still
can come in
require
later only.
biopsies and
Yeah.
others, is
Okay.
something I don't know
Okay.
if I'm
Okay.
okay with.
Yeah.
Yes. So now I have something. Mala, anything, or shall I go ahead
I
with the
think
last?
I was just thinking about your time. What time are
Yeah.
we?
This is the last part. So the couple now, who has never undergone genetic testing before, has undergone only kind of some kind of background evaluation for RPL, has come back to you with a third pregnancy, previous two miscarriage, living zero. And then now the question is that the routine screening protocol in women with RPL, will it be the same as that with other couples, or will there be anything different in the prenatal screening agenda for these couples? That's what I wanted to know. No testing has been done previously.
Right. So if they come to you during pregnancy, you lose the opportunity of testing for anatomical defects because they may not be very obvious. But certainly you should do your APLA testing and thyroid function test and antithyroid antibody testing
Mm,
because those are important.
mm.
There's no role of now testing the semen because you cannot take any corrective measures at this point.
Yes,
Uh,
yes.
but certainly, you want to rule out if a genetic cause is working. And for
Mm,
that, there has been a lot of research groups who are working on early
mm,
NIPT.
mm,
So, if
mm.
you can, currently we do NIPT at a gestational age of 11, 12 weeks, along with the NT scanning.
Yeah.
But there are many reports which say that after 9 weeks onwards, you may have good results with NIPT.
Mm,
And there is a particular group in Denmark which has published very recently that they can even do it at 7 weeks. So, 7 to 9 weeks is the window where
mm,
they want to test this fetus for a chromosomal abnormality
mm,
so that
mm,
the mother can be prepared if this is an abnormal child,
mm,
and she doesn't go through the trauma of losing that child and not knowing what was the reason for the
mm,
miscarriage.
mm.
I think currently our labs are not accepting anything below 9 weeks. Is that right, Priyadarshini?
Yes, madam. Yeah, we don't. I think, in fact, the general guideline is that send an NIPT sample after the dating scan. So after
7.
establishing parity. Yeah.
But I think there is considerable research in reducing the gestational age at which NIPT
Yeah.
can be accurately done, and we get a good enough fetal fraction. That is the concern when we're doing it very early.
Yes. Yes. Yes.
And one very
Mm,
important point to note is that if your patient is on low molecular weight heparin, then
mm.
the fetal fraction does
Yes, correct. Mm.
reduced, and the NIPT can come back as
No
non.
call. Mm, mm. So, anything more is looked for in women with RPL in the NIPT, or it is that's what I wanted to know.
So, well, if you're suspecting something, then of course you should
The
target.
targeted, the
Yeah.
targeted testing is should be
Otherwise,
available. Mm,
Yes, a lot of pregnancies now. The problem we face, we recently had a baby who had an inborn error of metabolism, a minor aciduria type of picture. She'd had an NIPT and that had shown normal results. And so the couple comes back and says, how come you didn't pick up this? But NIPT has its limitations. It is only looking for the aneuploidies of a few chromosomes, not all the inborn errors of metabolism or single gene defects.
Mm.
And vice versa, we had a couple that seemed very poor, and we did only quad screening for them. And they went on and had an abnormal child, and then said, why was NIPT not offered? So I think it is very important that you don't make that decision for them, because
Correct.
something goes wrong, they would say we would somehow get it done, if you had told us that
Correct.
test available.
Correct. There comes the medical legal angle.
So the
Should not,
medical
should offer everything and let them make the decision.
ACOG says all pregnancies should have an IPT, whereas there are no
Yes.
Indian guidelines. But I think
Mm.
that makes it important for us to offer it to everybody. Those who
Mm.
cannot afford it cannot
Yeah, I
afford
have
it.
it somewhere where ACOG says what
Yes,
ACOG requires you to discuss. ACOG says NIPT for all. Yes, I have it somewhere. But then we may not have time to discuss so many aspects of NIPT. I
right.
just wanted you to highlight this part and Priyadarshini and Priya to tell about expanded NIPT and Seema also to tell whether she has had any experience and we conclude. Yes.
Ma'am, I think Dr. Priya, you can go ahead and then I can add to this.
Okay, so expanded NIPT is done for two things. One, all the chromosomes, that's also called expanded, and they're also done for microdeletion, certain microdeletion syndrome like 1Q, 22Q, 1P, 5P minus, and things like that. Now, what is very important to note and well put in the slide is that the positive predictive value, that is, if it is positive, and the actuality that this baby really has a microdeletion syndrome is very low. So currently, ACMG, ACOG does not recommend expanded NIPT. NIPT remains a screening test and it's for the few chromosomes 13, 18, 21, X and Y. However, NIPT as a technology is improving day by day. We may be effectively able to give these in the future. Right now, the take home message don't offer, it's not good enough. But in the future, we might be still able.
But in a patient with, in a couple with recurrent loss, in a
No,
couple with
this
recurrent
no,
loss.
that is never has. So recurrent pregnancy loss again, if you have a cause, that's great. If
Mm,
not, look at aneuploidies. Most
mm,
aneuploidies which are of not 13, 18, 21,
mm,
they
mm.
actually abort, like they don't survive. The reason why 13, 18, 21 survives,
Yes,
unlike
because they
what
survive. Yes.
naturally
They
thought, is because
survive.
they have the
Correct.
least number of genes. They have the least number of genes.
Mm.
So that's why they're
So,
viable
as you
for us.
said, these are the issues which even Mala agreed with me that we should put this, that there is limited validation data, as you are saying already. And the SNPs, the single nucleotide polymorphisms used for ascertainment have so far been questionable. The size of the deletion matters, and some conditions are very variable. And the parents may be kind of, affected, but then we will be testing the fetus and thinking only the fetus is affected, but actually the parents may be carrying it already, but phenotypically not showing it, etc. And unanticipated results, as you said, it's quite a lot of difficulty which happens. So there is this situation where we say that go for NIPT the next or go for a PGTA, because whenever there are more aneuploidies happening, then whether you can opt for a pre-implantation genetic testing for aneuploidy and get it transferred, a normal one, or you should go for. So even when pregnancy results after embryo testing, NIPT is a must. So PGTA, even if it is done, following that pregnancy when it happens, the NIPT is a must. So I think we cannot kind of go around NIPT for testing. We should always do the cell fraction DNA, but with the limitations that it has. Am I right?
Yeah.
Yes,
Yeah.
ma'am.
Okay. Okay. So shall we? Anybody wants to say anything about PGTA in their practice? whether that has helped in recurrent aneuploidies, because RPL can have recurrent aneuploidies.
Yeah. So I think the important take home message here is that even if before implanting the embryo you have done a PGT testing, it is still vitally important to test this mother with an IPT once she gets pregnant, because the testing of the embryo could be fallacious in cases of mosaic embryos, in many other situations. So you cannot say that because this embryo is tested and implanted, this woman doesn't need prenatal testing. She still needs the full protocol of prenatal testing.
Thank you,
Ma'am,
Mala.
I would also like to add just one more point is that
Hmm.
whenever you are looking at an abnormality like the microdeletions, which has a very good phenotype on the scan and ultrasound,
Right.
doing a screening test doesn't make sense, because if you, even in cases of Downs, if you have a very high risk case, then directly an invasive test is advised instead of an NIPT, just when you're not doing an NIPT. So
Right.
I feel that that disorders where phenotype is clearly identified on a scan, one should always proceed for a invasive
Confirmatory
test,
test. Yeah,
and
because
save the
NIPT is still
cost.
a screening test.
Yeah,
And
it
so
will always be a screening test,
it will
right?
always
So
be a screening test. You have to confirm it by amniocentesis before you take a step of terminating that pregnancy.
Yeah.
So you are absolutely right. If there's enough evidence that this baby is abnormal, then you can straight away do amniocentesis. And also, if there is clearly a lethal abnormality in the baby, then there's no point in doing any antenatal testing. You might as well abort the baby and do the chromosomes after aborting the baby.
Correct. So, in general, the question asked chromosomal microarray of POC when, then we can answer that RPL is one of the situations, previous history and malformations, and any previous specific defects like microdeletion, etc. And when it comes to whole exome sequencing, then we need to understand that this is done whenever a single gene defect is a monogenic disorder is suspected due to the pattern of anomalies. And am I right? Anybody wants to comment on this?
No.
Significant structural anomalies with normal chromosomal microarray. I think we have made a point, right?
yeah, that is correct, madam. Yeah.
Okay. Key take home messages. Anybody can add. I'll soon stop sharing. So, natural prognosis in RPL is that 60 to 70% achieve live birth naturally. And please remember that this is quite achieved quite well when other than genetic disorders are picked up, like, for example, a septum is picked up or APLA is picked up, etc., then the chances of live birth are better. In genetic testing, we can say that 60 to 70% achieve live birth, even in balanced translocation carriers. So reassurance is important, as very early said in the webinar, and evaluation for all possible causes, especially in later pregnancy and with live anatomically normal fetuses are lost, then we have to evaluate for other causes. Testing the POC for genetic defect is the best way possible, is the chromosomal microarray, and clinical geneticists to play a key role. So, whenever you are talking about a multidisciplinary team in place for your obstetric work, add a clinical geneticist to the team. It is worthwhile. With that, I end my presentation. Stop share and I'll take the final comments and I'll take comment from the audience and we close. Anybody wants to share any case also? We'll start with Seema. Seema has not spoken for a long time. Sorry, Seema. No, you're mute, beta. You're mute.
So one thing I have seen in practice is when we ask the father to have a semen analysis, when they go to average labs, the semen reporting is so different from when they go to IVF labs for doing it. So as a practice now, I have made it a point to send all the males to IVF centers, because the teratozoospermia is not picked up by average labs. So that was one point I wanted to make for RPL patients, especially, you must see the quality of lab that these guys are getting, the semen analysis from, because we are letting the males go very scot-free, because most of the times, the reporting is very poor. Yeah, I think this was one. And sequential scans is something that I follow in my RPL clinics, that I've learned from Mala ma'am, that I call patients weekly to do a reassurance scans. This is something
Okay.
has been very, very good for couples, that they see fetal heart is normal, and I don't charge them for that. And I just see the cardiac
Yeah.
activity. So this is extended tender loving care.
Yeah.
Yeah, both points are very important. Yeah, I think it is important to do a proper semen analysis, and we have very few labs that do it. IVF center labs are more geared to do it. And yes, reassurance scans, there are papers to say that it improves the pregnancy outcome, because no matter how much you talk, deep down she wants to see the heartbeat to know is her baby alive or not.
Correct.
I just
Anybody?
wanted to know, is it do IVF labs, they do like if you send a general person sends their matlab the husbands for
Yes,
a semen testing, do they do it?
yes,
Because
ma'am.
I've never tried it, and the same things we feel, that the semen analysis is not always appropriate what you want. And
Yes.
many times they don't even take care of the timings. So the motility in one lab and the other lab is so much variation is there. So then that there is something. I mean, definitely it has not been done within the time frame. But of course, I don't know that do IVF labs entertain the general.
I do, ma'am.
Most of them will, because they will charge them for it. So why would they say no?
One or two questions I am picking up, Mala. One is if we do a very early NIPT, will there be enough fraction to
Yeah. So
test? Yeah.
I had replied to this that currently the early NIPT is in a
Yeah, yeah.
research.
Correct. You have replied.
So
Yeah.
we are waiting to see what their research shows. So far, they feel that they are able to do it. But if one lab can standardize early NIPT, it'll take a long time for all labs to come to that level. So it will take time.
So I must, Mala, there are a lot of compliments for you and for us
Ah,
as a
wonderful
team.
discussion. Wonderful
In
discussion.
the chat box, I
Dr.
must
Mala,
thank
Dr. Shubha,
Bharati.
both you
Yeah,
for.
thank you, Kiran. I must thank
Wow,
Bharati
you are
Rajshekar. I
great.
must thank Dr. Durgadas. Anyway, he is here. I must thank Tejavati, my friend from BSOG. I must thank Dr. Jyotika Desai. And Pragya, of course, thanks for coming in, sharing your experience. How can
And
I
what
thank
about
Kiran enough?
recordings? Can we?
Recording milega na, milega, milega. I'm just looking for
Because it
any
means
questions. I don't
actually,
want to mix. हाँ. So
Yes.
Anupama Sundar ने पूछा है. Anupama Sundar is from which society? अपना Bagalkot. Anupama. Madam, should we get CMA done immediately from fetal skin? I think no, Mala only
Yeah, I
has. Yeah,
responded to that,
yeah,
if
skin.
the skin is not macerated and it's a fresh abortus, then.
Achilles tendon.
But the thing that is preserved till the end is the Achilles tendon.
Oh God.
There's another question here,
It
Shobha.
is famous for more than one reason. Achilles tendon. Tell me, tell me,
There's a
tell me.
question here: in a case of skeletal dysplasia, very difficult to detect the site of gene abnormality,
Mm,
parents, and in fetus of 12 weeks. So now
mm,
they end up in going for IVF and donor embryo.
mm.
Actually, Priyadarshini, can I have your input? If there is a skeletal dysplasia, how difficult it is to identify the gene
So
locus?
I think Dr. Priya has
Yeah,
responded to
Priya
this
has
question.
responded, Mala.
And I think that she is right. It's I think one of the disorders which does have a good diagnostic yield is skeletal dysplasia. Most often times we are able to identify the variant. And if not a variant, see, most skeletal dysplasias could be dominant or autosomal recessive, and they come up with a clear-cut phenotype. So even an ultrasound is diagnostic for one, right? So why would you go for a donor egg? You still have a chance, like you said, you have a
A good
20, if it's a
marker.
recessive condition, you still have a 25% chance that the fetus will be abnormal. You still have a good chance that you can have a healthy baby. So I don't understand why one would go for a donor egg.
Yeah. Sorry, I didn't see Priya. Thanks for responding.
Yeah.
Yeah.
And many of the
Sometimes,
and many of the skeletal dysplasia, especially lethal skeletal dysplasia, are often dominant. That
Yes.
is de novo dominant. So parents do not even contain that mutation. So it
she
hardly
has
makes sense.
responded again saying that the couple had um, she had three skeletal dysplasias, and we did DNA
Okay,
storage also.
then it's
And
recessive.
WS couldn't find. So Malar Selvi has had a uniquely unfortunate experience. So she's sharing. Some cases can be that challenging. Yeah. And Dr. Ramaraju is also congratulating, and quite a few others. Sunita, Lakshmi, Prithviraj, everybody. And of course, Rajeshri is so supportive. Thank you, Rajeshri. Thank you, Dr.
Just
Durgadas.
before we conclude, just one more point. If you have a whole exome sequencing report that is not conclusive, and let us say a year has passed or something, it is always a good idea to get the data reanalyzed, because what happens is that even in a span of 1 year, a lot of new variants keep coming onto databases. So I mean, if the query isn't resolved and you're still trying to get pregnant, it is a good idea that in a period of 6 months to 1 year, you do a
Then we need to
reanalysis.
store it, isn't it,
No, the
Priyadarshini?
data is on the cloud. So
Okay.
yeah, I mean, you don't need to store anything. So
that was quite foolish of me.
yeah. So we
It's
can
quite
always
retro of me to think that.
we can always relook at the data once before
Yes, you're
we
right.
take a major decision. Yeah.
Yeah, correct. Thank you, Hema. Thank you, Nagmani and Anita. Thank you. Yes, I think. Thank you, Dr. Sundari. Thanks very much. Yes.
Excellent discussion. Excellent. Madam, the way it has been taken up from you started from collection and the examination of the product of conception. You took it so superbly up to the single defect, NIPT. The way of taking the topic was excellent. The deliberations,
Thanks.
everything.
Thank you
And
very
if you don't have any objection, we want to put it in the YouTube because everybody is asking. We Kasoga always record all these events, and if the host doesn't, I mean the guest doesn't have any objection, we want to put into the YouTube for the benefit of those who have not logged in today. Once again, Shobha, thank you for bringing this team.
Thank you, sir. Thank you.
Thank you, Mala, and the whole
Honestly,
team. Yes.
Yeah. And Dr. Durga, if you can share the recording, then we can put it on the IRPLF website too.
Yeah, we'll
Thank
do
you,
that.
Shobha.
Yeah,
And
we have
Mala,
recorded.
Malaji, after a long time, I am seeing you.
Oh, hi,
Somehow, like
Parimala.
we didn't meet in
I'm
any
a
of
great
this
fan
one.
of your flute because I am so unsuccessful at learning it.
And I'm not so well versed at
Thank
all
you,
also.
Pari. Thanks a lot, Pari.
Thank you. And
Dr.
it's very,
Shobha,
very
madam.
great because
Yeah.
Priya
Yeah.
Rangnath also, we also had a discussion very recently. I
Hi,
learned so
ma'am.
much from her, and it's so nice like to have each point, Shobha, even including your output. No less.
Thank you so much.
It's really
Pari,
great. And
actually, Priya has written something nice that we can always do more, and government hospitals offer DNA testing on research basis, and we can also check with them. Okay.
Thank you, Durga,
Honestly
for giving such
speaking, Dr.
wonderful
Shobha,
Pardon?
honestly speaking, even those who have attended, I feel the regular obstetrician doing the regular kind of work, we need to listen to this discussions again and again because
Again.
it's impossible for any average practitioner to register all that has been discussed today.
Correct.
And it
It is a
requires
little
more
bit
amount of
more
revision,
complex.
and a very, very complex topic. Although every point have been discussed and elaborately put up so very nicely, but in the algorithm of the situations and the clinical scenarios, I think we need to listen to this talk again and again. And for that reason, at least, we need to put it up on the YouTube because one listening is not enough.
Not enough. Thank you,
It's
Rajeshri. And I'm very, very
fantastic.
grateful to both the geneticists, Priya and Priyadarshini. Really wonderful inputs.
Excellent. Yes.
I'm really grateful to Mala. So much of expertise with her and Seema being here. It has made a really lot of difference. So,
Fantastic.
Thank you. Thank you, ma'am. It
Thank
was
you
a
so much.
pleasure.
thank you, Priya. Thank you. Okay,
Thank you,
Dr.
everyone.
Durgadas.
Bye.
Yeah. Anybody wants to say anything? I can see Jyotika there will join. Thank you for attending, Jyotika. Thank you, Pari. BSOG is such a strength for me. All the presidents joining, past president. What more can I ask for? It's very nice.
We are always
Thank you.
listening, Shubha.
Thank
Yeah.
you. Thank you, Jyotika. It's wonderful. So with that, I think Nagraj sir ಮಧ್ಯದಲ್ಲಿ ಏನೋ ಮೆಸೇಜ್ ಮಾಡಿದ್ರು.
He told it was an excellent discussion going on.
Okay.